Deep mycosis is increasingly being seen since AIDS has come up, and now with a growing population of immunocompromised patients, they say there is no fungal isolate which is non-pathogenic. Proper sample collection can give you a lot of information on the real cause of the infection. And if you have not collected it properly, you will miss the diagnosis. So let's see what is important while collecting the sample. So samples should be collected aseptically in a sterile screw cap container, leak proof container. There should be no swelling of the container from outside. The sample should be in adequate volume. Usually the fungal isolate is present in a very less dilution in the blood or CSF. Usually less than 1 colony forming unit per ml is present. So if sample is sent only 1 ml, there is very much likelihood that the isolate will be missed. And then clinician will be forced to look for other diagnosis or maybe higher test, more expensive investigations. So adequate volume of sample is very important in microbiology. Then sample should be well labeled, and a properly filled requisition form will give information about what tests should be used in the lab to identify the causative agent, because a wide variety of culture media and stains are available for different fungal pathogens. Ideally, samples should be sent before instituting the antifungal therapy. Sterile samples should never be refrigerated, and if there is a delay in sending the sample, then culture recovery gets compromised. Specimen are there is a variety of specimens sent to the lab. Now, which specimen should be sent in which infection is very important. Blood culture is the most important sample, and ideally 2 blood culture sets should be submitted. And if special media for mycology is available, it will all the more be good. Otherwise, routine aerobic and anaerobic bottles of the blood culture set will identify most of the fungal isolates. And if the incubation period is prolonged up to 10 days, then it will also increase the isolation of Candida glabrata, now called Nicasiomyces glabrata, and Cryptococcus neoformans. Intravascular catheter tips are the only catheters which are allowed for sending for culture, and they should be properly collected aseptically, and Marquis method of culture should be used. CSF should be sent in large volume, about 5 to 15 ml, and now quantitative culture with 100 microliter of CSF is recommended. BAL sample will give a lot of information for all pulmonary infections, and it can be used for microscopy, culture, antigen detection, and molecular testing. These are other body fluids, and they should be sent in sterile containers, and urine should be collected, clean catch midstream urine, and if that is not possible, then a catheterized sample is ideal. Aspirates from sterile sites and bone marrow can be directly inoculated in pediatric blood culture bottles on patient bedside. Drain fluid should never be sent beyond 24 hours of insertion of a drainage tube, because by then colonizer will grow. Biopsy specimen should not be collected in a gauze piece if it is being sent for fungal diagnosis, and never in formalin. Wound uh, swab should not be used, and a punch biopsy is ideal. And before collecting the punch biopsy, the wound should be debrided properly and cleaned with sterile saline. Swabs are not preferred other than oral and vaginal. Corneal scraping should be collected and inoculated on a blood agar plate or on a chocolate agar plate on the patient bedside. Skin, nails, and hair sample are collected for identifying dermatophytes, and skin should be collected from the advancing edge of the lesion by scraping. Nail should be collected by clipping close to the nail bed, and hair should be plucked and they should be sent in a clean black paper. Tissue should be preserved for future reference in case diagnosis is not made. Transportation of sample should be done as soon as possible, ideally within 2 hours. And for reference lab, a proper triple layer packing should be done, and IATA guidelines should be followed for infectious substances and for diagnostic substances separately. Alert the laboratory if you are suspecting some uh, uh, serious infections like coccidioides immitis, histoplasma capsulatum, or Talaromyces mannifie, which have hazard for the laboratory personnel handling them. Some fungal isolates need special media like Malassezia furfur, so it should also be informed. Surgeons should be made aware that they should collect sample for mycological identification from any mass lesion or any abscess and submit it to the lab for both microscopy and culture, because now it's being realized that fungal pathogens are responsible for many presentations like mimicking solitary nodule in pulmonary segments where it can mimic malignancy or even abscesses. They have been found to be caused by fungal pathogens because of increasing adaptation of fungi to higher temperatures due to global warming. And even immunocompetent people are getting affected by them. Microscopy is the most simple, sensitive, rapid, and cost effective test, and it can be provided even in remote areas. But technical expertise is required. So potassium hydroxide mount has remained a versatile test in a microbiology laboratory. But now calcofluor white stain is being more commonly used. It just needs a fluorescent microscope and few additional filters, and it is more rapid, more sensitive. So ideally this should be used in labs. Then India ink preparation has again got superseded by lateral flow device, that is a point of care test available for cryptococcal meningitis. And if it is being used, it should be used for CSF samples. It should not be used for sputum, pus or bowel samples because the viscous material can mimic the capsule in these. Then gram stain can give a lot of information about the budding yeast cells, pseudohyphae and hyphae. Modified Zeil-Nielsen stain will give information about nocardia. Giemsa stain will be required for identifying intracellular yeast like histoplasma, amergomyces. Histopathology fungal stains are done in a pathology lab, and they are very important besides culture to identify that this fungus is a true pathogen because it is invading the tissue. So mucicarmine stain and Alcian blue stain are used for cryptococcus identification. GMS is highly sensitive stain to identify the mole. Then Fontana-Mason stain differentiates the pheoid fungi from the hyaline mold. Pass will stain the fungal cell wall red. Routine histopathology stain like hematoxylin and eosin stain tells us about the inflammatory response in the tissue. and it helps in reaching the diagnosis. Then immunohistochemistry is available only in reference labs, and immunofluorescence also remains important for certain pathogens. Fungal culture and sensitivity testing is important to generate epidemiological data, because it is found that the species and sensitivity varies geographically from region to region depending on the use of agriculture, use of azoles. So fungal culture will take a lot of time for slow growing fungi. It can take up to 3 to 4 weeks. It is important to know that. And inhibitory mold agar is recommended because it has higher sensitivity than more commonly used separates dextrose agar. It isolates more number of fungi, which can be missed on other media. Then chromogenic media will provide rapid identification of certain species. Conventional biochemical tests also help in rapid identification for some species. Then automated systems are there. MultiTOF MS has become more important because of its rapidity. Various methods for doing antifungal susceptibility tests are available, but automated systems are more reliable, and some automated system like sensitivity tests provide information for moles as well. Molecular identification is growing with time, and because of its sensitivity and rapidity, sequencing has helped us in identifying the cryptic species and drug-resistant mutants, and it is also relevant in a situation of outbreak for identification of the strain. DNA probes are still used for culture identification in some labs. Serology, among this, antibody detection has remained a very important test in the past, but now it is not so important because it cannot differentiate between past and present infections, and it is an indirect method of detecting the infection. It has still some utility for coccidioidomycosis, histoplasmosis, and allergic aspergillosis. And complement fixation test has been abundant because of its complexity and cumbersome nature. Lateral flow devices are the norm of the time, and they are being increasingly used and devised for different fungal pathogens. The most important two infections, that is cryptococcal meningitis and disseminated histoplasmosis, are being diagnosed even in remote areas with the help of these lateral flow devices. Galactomannan assay for invasive pulmonary aspergillosis has been approved by FDA because of its rapidity of test, and now lateral flow device has become available in the market, and it can be used on both serum and bile, and it detects galactofuranose residue which is present in the growing hyphae tip, and it detects the invasiveness of the infection. The OD index, which is considered positive, is more than or equal to 0.5. And to increase the specificity of this test, now more than one cutoff is being used for serum and bile. The sensitivity and specificity of this test remains around 80% in neutropenic patients. So patient population and anti-mole prophylaxis, these two things influence the interpretation of this test, and with the use of anti-mole prophylaxis, the sensitivity decreases. There are many false positive responses to some antibiotics like piperacillin tazobactam, amoxicillin clavulanate, food and bacteria which carry the galactomannan on their surfaces in cases of mucosite endocytes. They cross the barrier and reach the blood and can give a false positive response. Similarly, IVIG and some blood products give false positive response. And it also cross-reacts with other opportunistic hyaline moles. But still, it is used in immunocompromised population of febrile neutropenia, where it has reduced the use of empirical antifungal treatment. And when the patient has still not presented with the symptoms, it can be used as a screening test bi-weekly to detect early appearance of invasive pulmonary aspergillosis in neutropenic patients, and then preemptive treatment can be instituted with antifungal drugs. Besides this, it also has a predictive value when serially tested in serum samples. So a rise of more than or equal to 0.25 after 1 week of a baseline titer predicts a poor outcome. Beta-D-glucan test, though it indicates invasive fungal infection, but it has a poor sensitivity of a wide range from 55 to 95%, and it is not positive for cryptococcosis and mucormycosis, and it gives positivity besides Candida, Aspergillus, and Pneumocystis for many other fungal isolates. And it has again many caveats with false positivity, so it has yet to find its niche in fungal diagnosis. Yet another important diagnostic test which should be available in a mycology lab is therapeutic drug monitoring. And voriconazole and posaconazole have very narrow therapeutic index because of their high toxicity at higher levels, and significant drug-drug interactions need that we should monitor their adequate plasma concentrations, and it should be closely regulated. So there is a need for more labs with mycological diagnostic facility with properly trained staff, as well as higher awareness among clinicians. I hope this talk brings you more insight. Thank you.